Good morning. I'd like to thank the organizers for the opportunity to present our research on the E39 peptide vaccine today. I have nothing to disclose. Endometrial and ovarian cancers are common in women and represent a significant cause of mortality. You can see here the American Cancer Society's 2017 estimates of incidence as well as mortality in these patient groups. Conventionally, these patients are treated with surgery as well as chemotherapy regimens that tend to be highly toxic with or without radiation. Despite current therapies, the majority of ovarian cancer patients and between 10 and 15% of endometrial cancer patients will recur, indicating the need for novel therapeutic strategies in these patients. Therapies that are targeted at the immune system can help to generate immunologic memory and thereby prevent recurrence in patients who have no evidence of disease at the time of treatment. The ideal tumor-associated antigen for targeted immunotherapy is going to be associated with more aggressive disease, and in addition will have higher expression on tumor tissues as compared to normal tissues in the patient's body. HER2 is a commonly known tumor-associated antigen in breast cancer. So peptide vaccines tend to be targeted against these tumor-associated antigens and are used to elicit a tumor-specific T-cell response, which are used to hopefully eliminate any patient's tumor cells. So like HER2 in breast cancer, folate binding protein meets the criteria for an ideal tumor-associated antigen in these endometrial and ovarian cancer patients, with the majority of these patients overexpressing folate binding protein, and there being up to an 80-fold increase in expression in tumor tissues compared to normal tissues. In addition, high folate binding protein expression is associated with more aggressive disease and a poor prognosis. So E39 is an HLA-A2-restricted folate-binding protein-derived peptide vaccine that has been shown to elicit a cytotoxic T-cell response against tumor cells expressing the FBP protein. These patients, this vaccine, therefore, is a good example of a targeted immunotherapy. However, the level of FBP expression has not been tested to determine whether that in itself would have an effect on a patient's response to vaccination. So our goal was to run a prospective trial of the E39 vaccine in these endometrial and ovarian cancer patients, and also to determine what effects their level of FBP expression will have on their response to vaccination therapy. So in this trial, we enrolled patients with primary or recurrent endometrial and ovarian cancers who were disease-free after completing standard of care therapies. A dose escalation scheme was used, which consisted of cohorts of 3 patients each receiving either 100, 500, or 1,000 micrograms of E39, plus 250 micrograms of GM-CSF as an immunoadjuvant. After the third patient in a cohort completed their third vaccination, their organ function was evaluated, and if they remained stable, the next highest dose cohort was initiated. Eventually, after initial evaluation of safety, the 500 and 1,000 microgram cohorts were expanded. FBP expression testing was performed on a patient's tumor sample prior to the start of vaccination using immunohistochemistry. These were graded at an outside facility 0 to 4 plus based on the percentage of positively staining cells. These were then categorized into low FBP expression if they were 0 to 1 plus or high FBP expression if 2 to 4 plus. We performed disease-free survival analyses on the overall control and vaccine groups and also on subsets based on their FBP expression. So the vaccine series consisted of 6 inoculations given intradermally every 3 to 4 weeks with an evaluation of organ function that occurred prior to the 4th vaccination. If they remained stable, they were continued on the series. So a total of 51 eligible patients were identified, and of those 51, 38 of them had folate binding protein expression testing results. They then underwent HLA testing, and HLA-A2 negative patients were followed prospectively as controls, while HLA-A2 positive patients were vaccinated based on the dose escalation scheme. You can see the numbers in purple here demonstrate that there was a relatively equal distribution of patients with FBP low and high in both the control and vaccine arms of the trial. There were no clinical pathologic differences overall between the control and vaccine groups. We also looked at the distribution within patients that were FBP high versus FBP low and found they were overall well matched, although patients with high FBP expression tended to have higher stage and also were more likely to have recurrent disease. This is consistent with the fact that these patients have a more aggressive disease at baseline. We also split them out based on their FEP expression and found within those groups they were relatively well matched. In terms of the toxicities, both local and systemic toxicities were relatively mild and represented mostly grade 1 and grade 2 toxicities. There were no differences between patients receiving the higher dose of 1,000 micrograms and those receiving less than 1,000 micrograms in terms of systemic toxicity. And in terms of the local toxicities, the 1,000 microgram group were actually a little bit milder. So there was no difference in overall disease-free survival between patients receiving the E39 vaccine and those in the control group. However, when we stratified patients based on the dose of E39 that they received, we saw a trend toward improved disease-free survival in patients receiving 1,000 micrograms when compared to those receiving less than 1,000 micrograms or the controls. This indicated to us that in this patient population, 1,000 micrograms was probably the optimal dose. We then performed disease-free survival analyses based on FBP expression and found that in patients with high FBP expression, there was no difference in disease-free survival. However, when we looked at patients with low FBP expression, there was significantly improved disease-free survival in patients who were vaccinated with E39. We then again stratified these based on dose, and in the FBP high group, there remained no significant difference based on the dose. But the effect that was seen in the FBP low patients was dose-dependent, with those receiving the optimal level of E39, the optimal dose, having improved disease-free survival compared to those receiving the suboptimal dose, followed by controls. So in conclusion, we determined that E39 is safe and well-tolerated in these patient populations, and we were also able to identify an improvement in disease-free survival in patients with low folate binding protein expression that was dose-dependent. This was not seen in patients with high FBP expression, which may be due to the fact that they have a baseline more aggressive disease and a poorer prognosis, or due to the fact that these patients may develop immune tolerance related to their higher FBP levels in the tumor tissues. Ultimately, this warrants more study of the E39 vaccine in these patients with low folate binding protein expression. Be happy to take any questions.
Very impressive results regarding disease-free survival. Did you guys look at overall survival as well?
We did not look at overall survival. Our main endpoint was 24-month disease-free survival.
Again, impressive work by your group. You guys come here very much every year. What is moving forward? What's your next step?
I think in this particular vaccine, we've already started looking actually in patients with ovarian and breast cancer, because there is overexpression of the folate binding protein receptor in breast cancer as well. So that's one area where we've looked. And I think based on these results, looking more closely and having an expanded subset of patients receiving the 1,000 microgram dose in that group that has low folate binding protein expression is going to be our next step.